All right, let's spend some time talking about the internal anatomy of the heart. So if you cut open the heart, you can see the four chambers from the inside. You can see the right atrium and the right ventricle, and then the left atrium and the left ventricle. And between the ventricles, you have a septum called the interventricular septum, meaning between the ventricles septum. Anatomically, that's right beneath the interventricular sulcus or groove that we saw on the outside of the heart. You also have an interatrial septum, although that's hidden right now by the great vessels, so you can't see it very well. In addition to the septa and the four chambers of the heart, here you can also see a set of four valves. So you have two valves that are called atrioventricular valves, meaning they're between the atria and the ventricles, right? And these are also called the tricuspid and the bicuspid valve. Now I remember this because the tricuspid's on the right where the blood goes first, and the bicuspid's on the left where the blood goes second. And you always try something before you buy it. So tricuspid, bicuspid. Bicuspid valve is also sometimes called the mitral valve, especially in a clinical setting. You might see people call it the mitral valve. These valves have to deal with a lot of pressure because as the ventricles press, they prevent backflow. Right, you want all the blood in the left ventricle to go out the aorta. You don't want it to go right back up into the left atrium, and so this prevents backflow from the left ventricle to the left atrium. And so to deal with all that pressure, you have extra little tendinous cords that we call chordae tendineae that hold this valve shut so it doesn't blow out the other direction. And you have these papillary muscles here that hold on to those chordae tendineae. Now, in addition to the two atrioventricular valves, the tricuspid and the bicuspid or mitral valve, you have two semilunar valves. You have a pulmonary semilunar valve, which is in the pulmonary trunk here. You can see it here. It has these three little flaps. Each one of them looks kind of like a half moon, hence semilunar. And you have a similar semilunar valve in the aorta, but again, it's kind of blocked. It's back here. But it looks just like this, only it's in the aorta. Now, these don't need to deal with nearly as much pressure as these, right? So they're anatomically entirely different. Right? They don't have these chordae tendineae attached to these flaps. They essentially just, they open up when blood pushes that way pretty easily, but then when blood falls back, it fills up these little pouches, right? And when they fill up, they get pushed together, and then it's hard for blood to go back down that way. Now you may also notice this within the right atrium. This is called the fossa ovalis. And your fossa is just like a depression, right? You may remember this from when you talked about bones in Bio 151. And the fossa ovalis just means like oval dip or depression, and you can see it right there. Now, we'll talk about this again when we get to fetal circulation. This used to be a hole or a foramen, and it closes up when you become close to being born. If you look at a cross-section of the heart, you can see that the left ventricle and the right ventricle are not equal. Right? Now, they're both much, much bigger than the atria in terms of the muscle in their walls and their myocardial layer because they both have to push the blood a lot further. But the left ventricle has to push the blood a lot further even than the right ventricle. So whereas the right ventricle has to go to the lungs and back, the left ventricle has to go to your pinky toes and back, right, through the whole systemic circuit. And so it makes like 4 to 6 times more pressure, and you can see this very, very thick wall, which again kind of looks like a circle back to the circumflex artery being on the left side. Here you can see the difference between relaxation and contraction, or diastole and systole of the ventricles. When your ventricles relax, they get larger, the pressure in them drops, and they become a vacuum. They suck in, and they open up these atrioventricular valves, and they suck blood in from the top, so they fill. When they do that, they also suck down here, and they've closed these semilunar valves. So the semilunar valves close before these atrioventricular valves open. And here's a different view, but you can still see semilunar valves closed, atrioventricular valves open. This happens during ventricular diastole or relaxation while the ventricles are filling with blood from the atria. when the ventricles contract, the opposite happens, right? They get smaller in terms of volume, create a high pressure, and then push that blood out, which means they close the atrioventricular valves, which prevent backflow into the atria, and they open up these semilunar valves and shoot blood right through. And here you can see another view again. In this case, the atrioventricular valves have closed, semilunar valves open. And the valves that shut always shut before the valves that are going to open will open. So this is during ventricular systole or contraction, which will shoot the blood out. Here's another look at some actual valves, semilunar valves, that you again find in the pulmonary trunk or the aorta, preventing backflow into the ventricles after ejection. And this is what it looks like when it's closed. Again, these are 3 pouches, and when they fill up with blood, when blood falls back down, these fill up and then creates pressure that pushes these corners against one another. Now, it's really hard for blood to go back down through there, but when blood's being pushed up from the ventricle into the vessel, then it's very easy to just sort of blow this out, and it just essentially becomes a tube. Now, these valves can be damaged. They can be damaged just from birth, right? Some people are born with damaged valves, and if some people can get valves that become damaged over time due to like plaque deposits, which is what this kind of looks like. When that occurs, they don't fit all the way together. They don't prevent backflow all the way 100% effectively, so you get a little bit of blood that will squirt back through here. When you have blood that goes through one of these valves, or the atrioventricular valves, it can change the heart sound that you get, and you can get a heart murmur. You can, a heart murmur, a very mild one, is not a big deal. You're just not getting 100% efficiency out of your heart. But if you have real damage in your valves, you can put prosthetic valves in there. These are bioprosthetic valves because they're not artificial. They actually come from pigs or cows, and then they are surgically inserted into your heart. Over time, your blood vessels can thicken and toughen the walls of those blood vessels, and this is called arteriosclerosis. And this can lead to coronary artery disease because it can lead to blockages or damage to the blood vessels that could burst, and this can lead to things like strokes. And the most common kind of arteriosclerosis is atherosclerosis. So this, again, it's a type of arteriosclerosis where you get lipid deposits inside the middle layer of the blood vessel, which is called the tunica media. We'll talk about that more next chapter. And this can stiffen and cause these walls to become brittle, but it also can block off some of the blood flow that you normally would have moving through that vessel, which obviously can be bad. This tends to be elevated with high blood cholesterol, specifically with high LDL, low-density lipoprotein cholesterol, which we'll talk about when we get to the digestive system. The older you get, you are at much higher risk for this. Males are at much higher risk as well. Again, if you have high blood cholesterol levels, high blood pressure, cigarette smoking can put you at much higher risk for atherosclerosis. If a doctor detects atherosclerosis, especially in an important vessel, for instance, leading to your heart, right? If you have a coronary vessel that has a blockage like this, they might send a catheter through with a balloon in it, essentially. And this is called balloon angioplasty, and they will send it in through a vein and snake it through all the way up to the vessel that's affected, again, often in your heart. And they will inflate that balloon and squish it all, the sides, kind of mush the plaque down in the wall of your heart. And if this is kind of a soft plaque, then this can be pretty effective. It's got a pretty high success rate and a very low surgical mortality rate. Often it can be done outpatient. This is kind of your most effective low-risk option for certain types of plaque. Now, if you get a large blockage that can't be fixed through balloon angioplasty, either through atherosclerosis or maybe some sort of blood clot that gets stuck in there, another way that you can fix this is by putting in a stent. So this is literally just a wire mesh tube that stays in there. So unlike the balloon, which they snake in there and just blow up temporarily to kind of mush down the plaque and then they take it out, this stent gets placed in there permanently. And this is sort of an angiograph. You can see then where the stent would go there to allow blood to continue flowing down this way. Now, if none of this works, they may have to open you up and do open heart surgery and do what's called a bypass, right? Where they essentially, they could put your heart on bypass, meaning they essentially reroute the blood around your heart, but also they can make like a separate pathway for blood to go like around the blockage or something like that. Now that's very invasive and very risky, right? It's open heart surgery, and they've gotten pretty good at it over the years. It's much less risky than it used to be, but they tend to avoid doing it if possible. So often if people open up your chest, they're going to do it when you have multiple blockages and you might have quadruple or quintuple bypass surgery because you have multiple blockages they need to take care of. Let's move on to the cardiac cycle. So there are two main phases of the cardiac cycle. If you're looking at it from the perspective of the ventricle, which is generally what you do because the ventricle is the prime mover of blood through your heart. And the first one is called systole, and that is contraction. And that's where you push blood out of the chamber. And then you have relaxation or diastole, which you relax and the chamber refills. Now, your blood pressure in your body tends to be a lot higher right after you pump, right? You contract. And so your systolic blood pressure, your blood pressure during systole of your ventricles is much higher, and your blood pressure during diastole of your ventricles tends to be its lowest, hence the two numbers in your blood pressure. Now, you do have two atria and two ventricles, but the atria tend to contract together and relax together, and the ventricles tend to contract together and relax together. So really, you have both atrial contraction and relaxation and ventricular contraction and relaxation. All of this happens in about 4/5 of a second. Now, as you can see, there's a long stretch of time where both the atria and the ventricles are in diastole, meaning they're relaxing. So let's go ahead and start talking about the cardiac cycle when all four chambers are relaxing. They're in diastole, and that means the ventricles are filling passively. They're just they're sucking blood down from the atria. And while due to suction from the ventricles and just gravity, most of the blood kind of moves down into the ventricles without the help of the atria contracting, the atria do contract systole to squeeze that last bit of blood down into the ventricle. Then the atria will relax, or atrial diastole, and the ventricles will begin to contract. Now they get smaller, which increases the pressure in the ventricles, and that causes the AV valves to swing shut. Now for a brief period of time, you have enough pressure to shut the AV valves, but not enough pressure to push blood through the semilunar valves to eject it. So even though you're contracting, it's isovolumetric because you're not changing the volume of blood in your ventricle. But as you keep contracting, the pressure raises and raises, and eventually you overwhelm any resistance from those semilunar valves, and you shoot that blood out via the aorta for your systemic circuit or the pulmonary trunk for your pulmonary circuit, and this is called ventricular ejection. Then you begin ventricular diastole or relaxation. Now they begin to relax, which decreases the pressure in the ventricles, right? Increases the volume, decreases the pressure. But there's a moment where you've shut the semilunar valves. Then you've sucked them shut, but you haven't sucked open the atrioventricular valves to bring blood down in from the atria, and so it's isovolumetric relaxation, which means same volume, because you're relaxing, but you haven't changed the volume of blood in your ventricles yet. Eventually, you continue to relax until you create enough suction, enough vacuum that you open up those AV valves and you suck a bunch of that blood down from the atria. Again, just like if you contract and release your palms, right? You can push air out and suck air in. The relaxation of your ventricles sucks blood in from the atria, and that and gravity leads to about 70% of the blood coming down from the atria, and then the last bit is pushed down by atrial systole, which we talked about at the beginning, or atrial contraction. And that is the cardiac cycle.